Thank you very much for joining the Public-Private Partnership for Handwashing at this webinar today. I'm Dr. Leila McKay, the Director of the Secretariat of the PPPHW. We're a coalition of international stakeholders who work to promote handwashing with soap and recognise hygiene as a pillar of international development and public health. In celebration of World Health Day 2015 and, of course, its theme of food safety this year, we are delighted to bring you a fascinating hour exploring how food hygiene impacts on child health and nutrition and how food hygiene can be implemented well in low-income settings. Today, we're going to hear from Julia Rosenbaum, Deputy Director and Senior Behaviour Change Advisor to USAID's WASHPlus programme, which is managed by FHI 360. And she'll be talking about why food hygiene is so important for child health and more about WASHPlus's small doable actions that mean we can all make a difference. Then we'll hear from OmPrasad Gautam, currently the Technical Support Manager for Hygiene for WaterAid UK. Om has been working in WASH research for over a decade, and he will tell us about his PhD research that has been about implementing food hygiene program in a low-income setting in Nepal. Finally, we'll move over to India and hear from the Chief of the WASH section for UNICEF India, Sue Coates, and UNICEF WASH Specialist Mamita Bora-Thakar, who will tell us more about UNICEF's work in achieving policy commitments to handwashing before the midday meal in schools in India. We're going to be taking questions at the end, so if you have a question, please type it into the question box, which is probably on the right-hand side of your screen. If you can't see the question box, then click that little red arrow at the top and it should appear. I hope that makes sense. And now I am delighted to introduce our first speaker, Julia Rosenbaum.
Thank you. Good morning, good afternoon, good evening to those of you on the line. On the occasion of World Health Day and Food Safety, as Leila said, I'm going to speak to you very briefly about why food hygiene matters for child growth. I'll do some to set the stage for all of our presenters and then speak briefly about a Uganda example. So to start, I'm going to ask you to think back when you last had food poisoning, what we say food poisoning, because for many of us it's an occupational hazard that comes with travel or living in the developing world, an occasional bad luck at a favorite restaurant or after eating leftovers kept too long. It affects 1 in 6 in the US, 1 in 5 each year in the UK, but in much of the world, poor food hygiene and diarrhea are directly linked to issues around child growth. In this brief presentation, we're going to explore those links, and we'll start to address what can be done to improve food hygiene and how to break this vicious cycle affecting so many. To start, evidence is lacking about the extent of foodborne infection, in part because the symptoms of foodborne infection really vary from quite mild and self-limiting to permanently disabling and fatal. And often surveillance reports simply diarrhea as a general category, but no specific etiology to link it to food or waterborne. And once a person is exposed to the pathogen, the time of onset of disease, disease symptoms really vary, ranging from a few hours to possibly weeks. So it's often really hard to link specifically to the specific pathogens. Next slide, please. When we look at the impact of food hygiene, you could click again if you would, diarrhea is still the #2 killer of under 5s after respiratory infection, and it's responsible for just about 11% of all child deaths. And very significantly, when we start looking at these links between nutrition, food hygiene, and diarrhea, we see notably that undernutrition contributed to 73% of those diarrhea deaths, so strong links. And undernutrition is the underlying cause of about 3.5 million child deaths each year, more than HIV, TB, and malaria combined. So it really still is quite significant in the overall panorama of child mortality and morbidity. It stunts the physical and mental growth of about 200 million children. And if you could go to the next slide, please. There's a very strong link between diarrhea and undernutrition, what we call a vicious cycle between the two. Undernutrition weakens the immune response, which then in turn increases the frequency, severity, duration, and mortality of common childhood illnesses like diarrhea, as well as measles and pneumonia. So what we see then is that children with diarrhea tend to eat less. They tend to eat less. With diarrhea, nutrients from the foods that they do end up eating are not well absorbed, and then in turn those undernourished children are more susceptible to diarrhea, and then you have the cycle continuing, that cycle going on. All this really culminates in what we call stunting, which is one of the 3 primary anthropometric measures that we use to measure child nutrition, which would be low, length, or height for age. And it's a sign of chronic undernutrition, so undernutrition over time, which affects about 162 million children, really 1/4 of all children under 5. So it's quite stunning when you think it through. It's 90% of those children live in Africa and Asia. So 1/4 of all children under 5, and most of those reside in Africa and Asia. And we're not just talking about small children. There for a while was a debate whether these were small but healthy children, but in fact it affects not only their height, but it also affects cognitive and emotional growth. If you could turn to the next slide, please. So we're not just talking about small but healthy children. A stunted child will never learn or will never earn their full potential. So this damage is quite significant, and essentially it can never be undone. It's essentially irreversible damage. And these effects are passed on to the next generation. So it's another vicious cycle, because children with less education and less earning power also bear children earlier and in poorer health themselves, so the cycle continues. Thank you. So as we're examining the relationship between diarrhea, nutrition, and stunting, we do want to look at what's causing all this stunting. The number 1 cause of stunting is a malnourished mother who would give birth to a small child, to a stunted child. The number 2 cause is poor diet, and often that's inadequate weaning foods over time. And the number 3 cause is diarrhea. And notably, diarrhea is the most important or the most significant infectious determinant of stunting. So again, we see this link with diet, nutrition, and diarrhea once again. Next slide, please. So our focus as public health professionals, our focus really is on how to reduce diarrheal disease. And there's a very strong evidence base now that improving hygiene and sanitation practices can have a dramatic effect on reducing diarrheal disease as well as reducing respiratory infections. So there has been an emphasis on improving wash behaviors, on improving safe feces disposal, safe storage and treatment of water, and hand washing with soap in order to reduce diarrheal disease. And on your screen in front of you, you can see the evidence base, the range of reduction in diarrheal disease through improvements in those practices. And traditionally, we have been focusing on those 3 practices as I mentioned them. But with some growing evidence now, we're starting to turn towards other wash practices. Those of you familiar with the environmental enteropathy literature, the environmental enteropathy hypothesis, we're now giving some more attention to animal and poultry feces. Also an emphasis on infant feces as well, impacting diarrheal disease. If you could go to the next slide, please. Keep going. Thank you. We're also starting to turn as well to look at this impact, however, on another wash behavior, and that would be, as we're talking about, the impact of food and food contamination on diarrheal disease as well. And this slide in front of us, if we could just unpack it a bit, if we would look at the vertical axis, This would be stunting, or length for age. And on the vertical axis, the 0 would be no stunting at all. That would be normal growth. And as you move down on the vertical axis, the minus 2.5, that becomes severe stunting. On the horizontal axis, that would be age in months, so age of a child. And then the colored lines are 4 different data sets. In this case, these are 4 data sets from Bangladesh, boys and girls. And what we're seeing in this diagram is that over time, you start seeing very severe stunting happening. If you could click on the slide one more time. Thank you. You start seeing very severe stunting happening just at the same time as complementary food is being introduced. You see the most rapid decline right in that 3 to 15 months at the same time in Bangladesh when you see the introduction of waters and solid foods, which is clearly indicating that it's the same time where you have contaminated food and waters. So what we're seeing is the impact of food hygiene on diarrhea and on stunting over time. Next slide. Thank you. So we have emerging evidence as well as a new focus on the role of food hygiene as one of those factors, as a very key factor in transmitting pathogens that cause diarrheal disease. And as I said at the start of this talk, we really don't have good data, but that we now have an estimate that it could be as high as 70% of diarrheal disease among young children could be due to pathogens transmitted through food and contaminated water in the process of feeding children. Thank you. Next slide. So if we look closely now, what causes foodborne disease? Well, there are a host of bacterial, viral, and parasitic organisms responsible. And in fact, there are probably 32 bacterial, viral, or parasitic organisms of public health import, and about 16 of those relevant to diarrheal disease affecting children. Many of those pathogens, some of them can survive on their own, but most of them have a reservoir either in humans, domestic animals, or household pests. So most of them do have a reservoir within that household setting and are spread through fecal-oral contamination. Again, for the most part, for parasites and viruses, the food itself serves as a vehicle for transmission to that new host. So the food itself is that vehicle. And for the bacterial pathogens, the food offers that opportunity for exponential growth. It actually multiplies as it sits there. So different actions happening between the bacteria and the parasitic and viruses, as you see happening. And then in other cases with some parasites and bacteria such as salmonella, the pathogen is actually present itself within the food. And then lastly, when we look what's causing this foodborne disease, the water that's mixed in the food preparation, and sometimes even during irrigation in growth and food prep, in growth can contaminate the food. So different actions causing that foodborne disease explained here in brief in the chart. Thank you. So what do we do about this? The World Health Organization in 2006 issued what they called the 5 keys to safer food. And you have them here in front of you, and they're actually quite simple and straightforward. It's clear messaging. Keep clean, separate raw and cooked food, cook thoroughly. It's quite simple messaging, but if you could get to the next slide. It's quite simple messaging, but in the situations where many of us live and work, and next slide again, it becomes quite difficult to enact the keys to safer food. So the challenge does become, how do we keep food clean, cook thoroughly, keep food at safe temperatures in cultures where hygiene is quite difficult, or for instance in this picture where dung is used for fuel, for building materials, where dung is not considered filth but in fact considered gold. How can we follow these keys to safer food? If you could go to the next slide, and then the next slide. Next slide, please. So what WASHPlus has set out to do is using the WHO 5 Keys to Safer Food and other evidence to set out how can we really come up with programming guidance that's based on solid programming evidence but is actually feasible for people to do. And what we do is use a behavior change approach that WASHPlus has developed for other WASH practices called small doable actions. And it's really based on the assumption and based on the evidence that people can rarely move from their current practice to ideal practices. They can rarely go from being sedentary to doing 5 aerobic exercises at one time. They really have to have some assistance. They have to make it possible. So they can't go from the current to ideal practice. And so what our approach is to identify and to promote what are called feasible actions, but that still have a public health impact. So what we'll do is do behavioral observations and construct a continuum of small doable actions that have that public health impact but are considered possible or feasible from the household point of view. And then with that continuum, we actually help to negotiate and pace people through the small doable actions towards the ideal. And if you could go to the next slide, please. So what you have before you now is a job aid that helps to visualize small doable actions. And if you could look on the line number 5 of small doable actions, this would be a pictorial of small doable actions around what would be the WHO use safe water. So if you look at a current practice, you have a water container that's sitting on the floor, animals have access, there's bugs all around. So that would be the current practice, and the ideal would be to have a jerry can with a spout with a spigot raised off the floor towards the ideal. And what we do is create that continuum. We say the continuum would be to raise the container off the floor. There may not be a jerry can, but there could be a plastic bowl that we might say we could dedicate that to be a top. You could make a ladle from a plastic bowl and a bamboo stick and make a ladle and hang that on the wall. Those would be the small doable actions that people could go from their current practice to an improved practice and be paced through. That's the example of doing small doable actions to move people from their current to an ideal or towards the ideal. Next slide, please. In food hygiene, a fairly standard approach that is used is called the hazard analysis to identify critical control points. And it's a very useful approach that we don't use in WASH typically, but it fits very well with this small doable action approach. And it can be used in households and in communities. And it really analyzes food safety from field to mouth, identifying areas of contamination. It looks at areas of hand contamination, water contamination, utensils, heating, and identifies really the most risky. But it prioritizes and it filters. It looks at what's most feasible, but from the householder point of view. So let's say, for instance, there may be a lot of contamination during food preparation. But in fact, let's say in a place like Bangladesh, if the food is actually boiled to death, if it's boiled, let's say rice and dal, so that the contamination is actually made safe during the boiling, then a critical control point, we wouldn't need to focus so much on the food preparation, but rather after the cooking, we'd want to focus on the food serving to the child. And a critical control point would be to focus on hand washing with soap before serving and cleaning the serving containers and implements. So that you're using the hazard analysis to identify critical control points, we'd focus on the hand washing and the serving containers. And we suggest that this approach might be quite useful as well for food safety. Thanks. On to the next. For time, I'm going to move a little bit quicker, but I do want to highlight that we have a very exciting new development. The USAID Fanta project has just released today, also in honor of the World Health Day and food safety, a literature review that's cited here on the bottom. And what they've done is reviewed all the literature and from 14 studies have identified critical food hygiene actions. And they're listed here on the screen. And many of them have to do, as you can see, cooking food at adequate temperatures and time, decreasing the time food is stored at ambient temperatures, reheating at adequate temperatures, use of clean utensils to avoid contamination, food storage, and adequate hand washing to avoid contamination. These 6 actions have been found across the published literature to be, if you will, the most effective at reducing 15 to 70%, reducing contamination, and the most effective actions. And we suggest that these could be the starting point in investigations to then customize in particular contexts your interventions to improve food hygiene. So it's a very exciting new release, and you'll find a link to this, a technical brief that summarizes and the new literature review, both on the PPPHW website, the WASHPlus weekly and website. You'll find it as well as on the FANTA website very soon, so please look for that. Next slide. I told you about the small doable action approach, and very quickly what you have pictured here is a job aid where we took the small doable action approach in Uganda and we then prioritized small doable actions for food safety. Here we had house-to-house actions to negotiate priority small doable actions at the household level. And one of the most challenging things in Uganda was an absolute shortage of water for hand washing and utensil cleaning. And so one of the small doable actions needing to promote, if you go to the next slide, one of the small doable actions that we promoted was making rainwater catchment systems so that we could increase the absolute quantity of household water. So a fairly unique take on food hygiene and food safety, if you go back one, here was to promote the small doable actions of rainwater catchment, just as one example of taking the small doable action approach to improve food safety. So what I've tried to do here is to jog you through really why food hygiene matters for growth and give you some simple approaches at the field level to address how to improve food hygiene. And now we'll hear one more example from our colleague, OmPrasad, of how to also address food hygiene at the household level. Thanks very much.
Thank you very much, Julia. That was great. And for those of you who have questions for Julia, please just type them into the little message box on the right and we can address those at the end. And now I'm delighted to introduce OmPrasad Gautam from WaterAid UK and London School of Hygiene and Tropical Medicine to tell us about his research in Nepal.
Thank you, Hannah, for the nice introduction. Good morning, good afternoon, and good evening to everyone. First of all, I would like to wish you a very happy World Health Day. Fortunately, this year, UN is shining a spotlight on the impact of poor food hygiene. On behalf of those of us working in the field of food safety and hygiene, it's about time. So let's discuss about the most neglected domain of work in the field of water, sanitation, and hygiene, wash, health, education, and nutrition sector. In my presentation, I'm going to highlight the food hygiene in low and middle income countries with specific reference from Nepal. Next slide, please. To start with, as we know that inadequate food hygiene is likely to account for a substantial proportion of gastroenteric infection, childhood undernutrition, childhood diarrhea, and foodborne infections. It is likely because bacteria, virus, parasites, fecal matters, and the chemicals are a common part of the daily diets of the millions of children across the developing world. As a result, as you can see, diarrhea is still the second leading cause of under 5 mortality globally, which kills around 70% of the, which kills around 700,000 under 5 children every year. Unfortunately, around 70% of diarrheal episodes in low-income settings are regarded as foodborne and are due to pathogen transmitted through food. The contaminated weaning food in particular has been suggested as one of the major contributing factors for those infections. As you can see in the slide, the weaning food has been heavily contaminated in many of the low-income settings. For example, 16% in Zimbabwe, 36% in Nepal, 41% in Bangladesh, and 44% in Egyptian village were contaminated with pathogenic form of the E. coli. From the public health point of view, as we know, pathogenic form of E. coli accounts 25% of the bacterial disease, and there are multiple factors contributing for this infection. Next slide, please. Foodborne infections universal both in high and low income settings. Fortunately, in income settings, we can quantify the magnitude of the problem. For example, in UK, 1 in 5 people develop gastrointestinal illness. In US, 1 in 6 people get sick of foodborne disease. But unfortunately, in low income settings, we have lack of evidence both from research and surveillance. But what is known about foodborne infection in low-income settings are based on expert opinion and biological plausibility rather than field evidence. So we have very limited studies. So far, we have only one community-based cluster randomized intervention trial, which was conducted in Nepal, and I was fortunate to lead that trial. So I'll be highlighting most of it in my subsequent slide. So there were only 2 intervention studies using hazard analysis and critical control point methods that was conducted in Bangladesh and Mali. Demonstrated the significant results in terms of reducing the level of contamination in food using HACCP principle, but replication of those principles in community setting is still a challenge. So there were other 2 small-scale behavioral trials tested the feasibility of different behaviors, but the replicability of those behaviors in a community setting is still questionable. And there was a WHO initiative called 5 Keys to Safer Food Educational Project. But from those initiatives, we know that those initiatives has been implemented in many of the developing countries, but we don't know the effect of those interventions in terms of improving behaviors and reducing the child mortality. So in conclusion, what I can say, there is a little effort to integrate food hygiene as part of the intervention for the reduction of childhood diarrhea and undernutrition from different sectors, because these initiatives implies equally for WASH, health, education, and nutrition sector. So there is a minimal efforts from all these sectors to highlight the food hygiene initiatives and food safety aspects. Next slide, please. The question then from different sector can come whether or not this has been prioritized from different sector. Why this was not prioritized? I would say this is still a missed opportunity from different sector, despite the fact that food is one of the critical pathway by which fecal pathogen can be transmitted to new host. When fishes are concerned, we are primarily focusing on water supply and sanitation from waste sector, food supplementation from nutrition sector. So my argument here, if a specific sector has to maximize the benefit of our current investment on water supply and sanitation or from nutrition sector, we have to deal with the different pathways, and food is one of the key pathways we need to hammer. Therefore, we need a scalable, simple intervention practice which can be replicable in a wider setting. If we fail to do that, if we fail to address the food hygiene, the children will continue suffering from the diarrheal episodes. Children will be malnourished and stunted, and we will compromise the cognitive development of the children. Particularly for me, as I grew up in Nepal, I saw the first devastating effect of the poor food hygiene on child health. In 2009, there was a single diarrhea outbreak that killed around more than 350 children, innocent children, from the diarrhea episodes. The investigative report fairly ignored the fact of the contribution made from the food hygiene. Despite the fact that Nepal has made some progress in terms of reducing the child mortality, but Nepal is one of the top 10 countries in terms of stunting prevalent still. That is why I sort of determined to do a PhD research on food hygiene, thereby to minimize the research and programmatic gap, not only in Nepal but also across the different low and middle income countries. Can I go to the next slide, please? In order to address this problem, a food hygiene intervention trial was set up with an aim to design, execute, and assess the effect of simple and scalable food hygiene intervention on mothers' food hygiene behaviors as a primary outcome, and on the level of microbiological contamination in child food as a secondary outcome. So this was a cluster randomized before-after study with control. Next slide, please. In order to design, execute, and evaluate the trial, I use a systematic approach. We use behavior-centered design. We call them ABCDE principle. So in A, I assess the existing knowledge in the sector. So I did a systematic search in order to understand what has been already done in the sector in terms of food hygiene and food safety. So there are, as I mentioned earlier, there are very minimal studies that demonstrate the successful transition of improving the behavior. But but during that phase, I learned a lot from the other intervention, other behaviors and intervention, including hand washing with soap and other studies. From A, I jumped to B in order to build my understanding by doing the formative research in the context, in the particular settings. Through the formative research, I sort of understand the behavioral determinants, the physical, social, and biological determinants, the behaviors, the barrier and mode for people to perform certain behavior, and also identify the critical control points by doing a hazard analysis and prioritize the key behavior from the formative research. The formative research was then informed the design of the intervention package. So in C, I sort of curated a design with in a curative process with the help of curative team. So in D, that curative package was rolled out in a campaign approach over a period of 3 months in an intervention cluster. So at the end, the whole effect of the intervention trial was measured before and after for the intended outcome. So can I go to the next slide, please? So the intervention was trying to address the before that, the intervention was trying to address the 6 behavior. So in order to address those behavior, we need to design a more of a simple and a scalable, more of an innovative package, because we know that the changing people's behavior is quite challenging and difficult. We need to understand the unique perspective of the people by which we can design a package. In order to design that package, as I mentioned, I did a formative research. Through the curative process, the simple package was designed. While designing the package, we use a novel approach. So what I mean by novel approach is we have to move away from the standard educational approach. We were trying to move away from the cognitive model, the knowledge improvement part, to the actual behavior improvement using the more of a creative and innovative science of behavior change. So use those elements while designing a package in order to change the people's behavior. So the overall the intervention package was implemented over a period of 3 months in an intervention cluster, targeting to a mother with a child from 6 to 59 months in 8 intervention clusters. The overall campaign was implemented through 6 community events and 6 household visits, followed by some elements in the school. So whole campaign was implemented by trained female community health volunteers. They were the pioneer for the public health intervention in Nepal. We used a campaign approach to implement the whole trial with a theme called Safe Food, Healthy Child, and there was a desire for any target population to practice the behavior. So that desire was to be an ideal mother, because we are primarily targeting to mothers and grandmothers. So for mother and the grandmother to practice all 5 behaviors that we prioritize, the desire was to be an ideal mother. So can I go to the next slide, please? So the prioritized behavior were only 5. We only targeted 5 behaviors that were unhygienically practiced. But through formative research, we sort of try to map out which particular behavior should address. So formative research informed that we should target 6 behavior based on the hazard analysis, micro assessment, and the behavioral assessment. But when it comes to prioritization and the prioritization for this intervention trial, because many of the people thoroughly cooking their food, therefore we only targeted from 1 to 5. Now I want to quickly go through all the behaviors, why these behaviors are important, why should we target this behavior. The first behavior, the thorough cooking. We should target thorough cooking because it kills most of the vegetative form of the bacteria if we maintain the adequate temperature. When I say adequate temperature, we need to maintain at least 70 degrees. So as soon as the food is thoroughly cooked, then we are going to serve that food through the serving utensil, either through a plate or bowl. That has to wash or clean just before putting the food. That way we can minimize the contamination. The third behavior then people are going to use, mostly in developing countries, people use spoon or hands, mostly hands I would say, they use to feed their children or eat by themselves. If people actually practice these three behavior, the thorough cooking, the cleanliness of serving utensil, and hand washing with soap before feeding or eating, we are actually going to eliminate or control the level of infection in the food. The another side of the coin is world is not that ideal. In many of the developing countries, people cook once a day, feed multiple times to their children or eat by themselves. Therefore, but due to lack of refrigerator, they can't maintain the proper temperature in order to store the food. So the third behavior that then we targeted were the proper storage using lid, at least to minimize the cross-contamination. However, that stored food has to be thoroughly reheated to kill the bacteria before serving to anyone. So once they reheat the food, the cycle continues. They need to clean the serving utensil and wash the hands. So if all these five behaviors happens, we can actually eliminate the level of contamination. I'm going to show you the details, the impact of the story later on. So in addition to that, together with the food, in many of the countries, people fed both milk and water. So those milk and water has to treat before feeding to the children. Yes, I think we lost some slide. Yes, okay. Can you go to the next slide, please? Yes, therefore, through the formative research, the 5 behaviors were prioritized and targeted. So it was easy to sort of prioritize the behavior, but the difficult part is how to change the people's behavior, how we can make that package, the intervention package, motivational in order to change the people's behavior. So in this food hygiene intervention trial, we used the novel elements of behavior change. Those elements were changing the behavioral settings, the physical settings, the biological settings, and the social settings. In physical settings, let me cite you an example from typical rural village in Nepal. The one single room in a household served multiple action. The people had to cook the food, feed their children, sometimes sleep inside that particular room, and also sometimes keep animal inside on the same room. So for anyone in the household, practicing all 5 behaviors on that particular setting was quite challenging. So without disturbing that particular setting, it was very challenging for us to promote the behavior. So we came up with the idea of the kitchen makeover to demark that particular kitchen in one of the corner, and then we use a bunting to demark and put an eye dangler as a reminder to practice the behavior. So that way, that particular room, can I go to the next slide, please? That way, that particular room looks clean, bright, and beautiful, so that everyone in the house feel, okay, this is our new kitchen. We need to practice the behavior. So the eye dangler also reminds the behavior. If you look at those eye danglers put in the different places in the picture in front of you, as soon as people wants to add certain behavior, for example, in the storage, if they want to take out the storage food, and immediately when they reach there, that will remind them to reheat the food. So putting a specific eye dangler in a specific behavior place was instrumental in order to remind people. And the changing behavioral settings was helpful to remind mothers and also motivate mothers, encourage mothers for the actual behavior. Next slide, please. The other novel elements of the intervention trial was use of motivational theme, the emotional driver to change the people's behavior. So we didn't use the cognition model or improving knowledge model in our intervention trial. So we use a motivational theme. Those motivational drivers includes nurture, disgust, social respects, and affiliation. So in my subsequent slide, so I'm going to highlight the few campaign activities which were used to motivate mothers in order to practice the behaviors linking with the emotional drivers. So can you go to the next slide? So I'll highlight some of the activities that are linked with the different emotional driver. For example, we use nurture. We use nurture as one of the motivational factor for mother to practice all 5 behaviors. So nurture motive was used to create a desire for a happy, thriving child by performing all 5 behaviors. So the different activities were used. One was child life game. The child life game demonstrated the real life differences of the mothers, those who practice all 5 behaviors, those who didn't. And what had happened during the child life game process, there was a clear demonstration that if mother practiced 5 behaviors, their child will be in some stage at the age of 30, and then if they didn't, their child would be in some way. So that by showing the child life game, there was the huge difference for mother to look the different aspects of the hygiene behaviors that actually encourage mother to perform the behaviors. So the other elements were the storytelling, the family member role play, and public commitments. I think you jumped too ahead. Can you go back one slide, please? Because I haven't done the discussed, the earlier one, please. Yes, the discussed. The next motive, yes, the next motive was discussed. The discussed motive was used to create a desire to avoid and remove the contamination, particularly the dust, by performing all 5 behaviors. For that to happen, we use a glowworms. Just before feeding their children, we use a glowworms in order to demonstrate how dirt can contaminate the child food. The other elements, we use a 3M petri films to show the level of contamination in food. That was a real life demonstration for mothers to actually visibly see the bacteria in the food. We use a disgusting picture demonstration and hot potato game to demo how how people practicing unhygienic behavior in the society can actually be excluded if they continue practicing a behavior, because people is not going to tell, but if someone practices the unhygienic behavior, definitely their status and their behavior is of course disgusting for other people. So by demonstrating that one, we sort of trigger and motivated mothers to practice the behavior. The next slide, please. The next motive was affiliation motive. So affiliation motive was used to create a desire to fit in with what others in the reference group are perceived and doing. So this was basically creating a social norm in society by using different activities. The one activity that I particularly want to highlight was the use of beep. So the beep was introduced during the intervention trial. So mother had to put on a beep just before feeding their children, and the beep had a message called, "Did you wash your hands before feeding me?" So as soon as mother started putting the beep in the child's chest before feeding, that will remind mother to practice to perform that actual behavior. So other elements to elicit the affiliation motives were the puzzle game and folk song. So it will take some time to explain everything, but I just want to give you the glimpse that what were the activities that actually used to motivate mothers to change the behavior. So next slide, please. The last motive that we used was social respects and the status. This motive particularly used to create a desire to increase their social respect, because by performing the food hygiene behavior, anyone in the village should feel that if we practice all 5 behaviors, our social status is going to increase. For that to happen, there were 3 competitions. One was clean kitchen competition. The clean kitchen competition, after performing the clean kitchen competition, majority of the household win the clean kitchen competition. Those who win the clean kitchen competition, they receive the prize publicly. And the second competition was ideal mother competition. Those mother who became the ideal by practicing all 5 behavior during the trial period, their photos put up in the junction of the village. You can see their ideal mother photos we put up in the junction of the village for their social respect and pride. So that way the mother's social status increase. The last activity, last social respect affiliation motive related activities was the declaration of the safe food hygiene zone. There were altogether 8 clusters. Out of 8 clusters, those clusters who had all household clean, all mother who became the ideal mother, those clusters declared as a safe food hygiene zone, and the safe food hygiene zone billboards were put up in the junction, in the entry point of the junction of the village. Therefore, they feel pride. Oh, this village is called as safe food hygiene zone. So we should be practicing all 5 behaviors. That way, we sort of motivated mothers to continuously sustaining the behavior. So next slide, please. So those were the key sort of activities that I use in order to encourage mother to practice the behavior. So as a result of the intervention trial, the 3 months intervention trial, as I mentioned earlier, the effect of that intervention was measured before and after. During the baseline, you can see in the slide the proportion of mother practicing all 5 behaviors. When I say all five as I shown you earlier, in the intervention group, only 1% of the mothers practice all 5 behaviors. In the control group, only 2% mothers practice all 5 behaviors. After the 3 months intervention trial, the proportion of mother practicing behavior went up to 43%, and that remained constant in the control group 2%. So the effect size of the intervention, the difference of the intervention, the actual attribution of the intervention was 42% improvement. Next slide, please. So the intervention was also equally effective to improve all food hygiene behaviors. If you look at the different behaviors, the cleanliness of serving utensil, the proportion of mother practicing cleanliness of serving utensil went from 3% to 55%. If you look at the hand washing with soap before feeding by mother, from 5 to 67%. Same for children before feeding, 5 to 67%. So the intervention was equally effective to improve all 5 behavior across different cluster. Next slide, please. In the behavioral trial intervention, often criticism is people tend to change their behavior for certain time frame, but if we fail to demonstrate the effect, the impact of that changed behavior is very unlikely that we'll be getting some of the health impact. So in this particular trial, one of the intermediary outcome that we wanted to measure was the food safety aspect, the level of microbiological contamination in food, whether or not improved behavior actually reduce the level of contamination. So we measured the level of contamination in food before and after in both the group. I just want to show you the effect of that intervention in the intervention group. If you look at the first slide, the middle graph, while feeding, the level of contamination out of 40 samples tested during baseline, the level of contamination in 29 of the sample were more than 100 per gram of food, like heavily contaminated. 29 sample out of 40 were heavily contaminated with the total coliform. If you look at after the intervention, in the next in the subsequent bar graph below, out of 40 sample, the 30 sample had no level of contamination. So that means the intervention was hugely effective in order to reduce the level of contamination in food as well. So next slide, please. So our conclusion from the intervention is, and also through the systematic approach that we use, we want to conclude that the systematic approach employing the emotional motivators, as I mentioned, the use of disgust, nurture, the affiliation and the social status motives, and changing the behavioral settings was useful in order to improve the people's behavior. The 5 simple measures significantly improve the food safety, particularly reduce the level of contamination in food. What we found throughout the process was neglecting one or other behavior compromise the outcome. As I mentioned earlier, if we continuously promoting thorough cooking, if we fail to promote hand washing with soap, all our effort for promoting thorough cooking will go in vain. At the same time, if we miss to promote thorough cooking or reheating and only continue promoting hand washing with soap, people might have washed their food, hands, but due to the contamination happened during reheating and cooking, people still consume the contaminated food. Therefore, compromising one or another behavior will compromise the outcome of our intervention. So the last conclusion from our intervention trial is basically we came up with the scalable food hygiene intervention trial, which can be delivered from different public health intervention, from health, wash and nutrition program in many of the low-income countries, but it has to be contextualized. As I said earlier, the behavior happens in different settings and different contexts. So this package, if we want to replicate in other setting, has to be contextualized. So that was the conclusion from the overall intervention trial. With this, I would like to conclude here and invite the other speaker.
Thank you very much, That is really fascinating and great for us all to hear. And now we'd like to move to our final speaker. We're delighted to welcome the Chief of the WASH section for UNICEF India, Sue Coates. Thank you very much, Sue.
Hello, thank you Hannah, and greetings from UNICEF India in Delhi. I'm here with my colleague Mamita, who has done much of the work that I'm going to describe. So building on the presentations that you've already heard, and without repeating the evidence, we would like to share our journey and experience around how we've been able to use hand washing with soap, and specifically group hand washing, to reposition the Wash in Schools agenda in India. This is then the story of how we've taken the evidence and applied it. Next slide. So let's first look at the numbers. Numbers in India are about sheer scale. India accounts for the highest burden of child mortality and morbidity. You can see from the numbers that we're talking about not a few million, but hundreds of million. 595 million people defecate in the open. 61 million children are stunted, and we have over 1.3 million children dying before they turn 5. 40% of all child marriages happen in India, and this is important when we think about how many children we're maintaining in schools. Too many of our adolescents are marrying before they're ready to have children, and hence prematurity of newborns is the highest cause of death in the country. Of course, this scenario is due to many factors, and wash in schools can't solve all the problem. However, if we can keep children in school, and if we can ensure better hygiene and health within the school environment, then this is a big part of the solution. The good news is that some 11 million more children have enrolled in schools since 2010, and it's against this background that we are repositioning wash in schools. Next slide, please. This slide is quite complicated and quite busy, but where I'd like you to concentrate on is the top corner in red that talks about the Government of India programs and theories of change, and the line that comes after that, the pictures. UNICEF in India provides technical advice to national and state governments. We do not implement programs, but we demonstrate what works and why. We work closely with the government to articulate theories of change. And for us, school-age children are part of a life cycle approach and also part of the health and nutrition continuum of care. And these are shown in the photographs along the top of the slide. We focus therefore on touch points where the impact is greatest. Our physical focus is in the home, in the community and in facilities, schools, health centres and preschool centres. Our wash interventions, which are shown below the life cycle on the slide, protect vulnerable mothers and children who live in very toxic environments that are high in bacteriological contamination. They also, of course, offer dignity. The grey boxes are where UNICEF makes its contribution through technical support, and the text in blue describes our strategies. So this slide is showing the context and the context of how we are now positioning the work we're doing. Next slide. When we look at the situation of washing schools, it's not all bad in India. For example, we see an increase in the number of schools with separate toilets for girls, and therefore coverage is not the biggest issue. India can and does build toilets in schools. However, when we look at access and use, we hit problems. Too many schools have toilets which are locked, too many have toilets which are far too dirty to use and which prohibit children from entering them. So if you look down the table, you can see that we have statistics for toilets, for girls' toilets, and for drinking water. But interestingly, in this national monitoring system, we also have lines which include the midday meal and nutrition in schools. The important factor here is to note that washing schools is being monitored as part of the Right to Education Act. And this monitoring is extended not only in the national system, but also in the independent systems which verify the national data. This table is one such example of independent monitoring. Next slide. So let's look at the bottlenecks for WASH in schools. Analysis of the data shows that the persistent bottlenecks are the lack of dedicated funds and institutional systems for sustainable operation and maintenance. Our experience tells us that we must also grapple with very deep-rooted perceptions and attitudes about cleaning toilets. Good hygiene behaviours and habits do not exist across the school community. So even when funds are available, there is simply no guarantee that toilets will be kept fit for purpose or that hand washing with soap will be practiced. Next slide. Given this background, and because of the vicious circle around operation and maintenance, we went back to the drawing board. We scanned the environment to look for the best entry point to secure a firm foothold for WASH in schools. We wanted this entry point to break what had become a vicious circle. Business as usual for WASH in schools was not working. Our entry point would now be nutrition and school feeding. And if you look at the slide, I've highlighted that we were receiving in other sectors in India growing attention around school-aged children and adolescents, the fact that over 30% have a very low BMI and that over 50% of adolescent girls are anemic. There is also increasing studies and investigation and interest in micronutrient deficiencies, and worm infestation remains high. This was a pragmatic decision based on the fact that a substantial number of India's 595 million open defecators are children, and most of these children take their nutritional benefits from school feeding programs which reach 110 million children every day. So here we have an opportunity to add hand washing with soap to an existing school routine, a routine that is driven by ritual, by habit, by discipline, and by order. We could also begin to understand our contribution to reducing micronutrient deficiencies and really home in on where people are interested. Most importantly, we found a hook that links the nutritional status of children and adolescents with their health and hygiene status, their school readiness, and educational outcomes. Learning from the work in the Philippines, as you can see in the two pictures here, we introduced group hand washing. This was our new entry point. We had taken the ideas from various forms and various pilots using different technology. We didn't get overcomplicated with what we were trying to do. In some instances, we took a pipe and made holes in it. The big message was that we had an efficient and effective way to have hundreds of children wash their hands in a short space of time. The important message is that clean hands now touch food that go into the mouths of hungry children. This simply was not happening before. We also extended this message to school cooks and teachers. Next slide. Here again is a reminder of the scale. 110 million children in 1.4 million schools. So what next? It's okay demonstrating a new technology. It's okay linking hand washing to the midday meal. But what we needed to do was institutionalize this practice. In early 2013, the Ministry of Education requested that all state governments institutionalize hand washing with soap before the midday meal. This included allocating enough time and also making sure that the new routine would be monitored. We now have the potential to reach 110 million children in 1.4 million schools. We also ensured that any new kitchen sheds being built by the government included group hand washing facilities. This is a simple move that has impacted 300,000 new kitchen sheds over recent months. Most recently, we've had great success in securing within the new food safety and hygiene guidelines a directive that all schools include hand washing with soap before the midday meal. And this directive includes not just the children but cooks and teachers. This means that the monies and the funds can start going to this practice, and this practice is happening in school. Persistent advocacy coupled with large-scale demonstrations is finally in India beginning to pay off. Next slide. States are picking up this approach rapidly. In the field we see different design technologies, but they all follow the same principle. The children wash hands with soap and group before they eat the midday meal, supervised by teachers or the midday meal worker, supported by adequate time allocation. States are providing resources for soap and simple hand washing infrastructure. Here you can see two examples from different states. Importantly, state governments are now taking their own demonstrations to scale, and scale means tens of thousands of schools as part of a pilot or demonstration. Next slide. So, what are the big wins for washing schools in India? First of all, taking the evidence as described in the two previous presentations this evening and the literature, we have secured new champions. And we have secured new champions by simply showing that something is possible. The Education Ministry and the Midday Meal Programme are committed to wash in schools. In fact, with the change of government, the ministries have changed, and the Ministry of Education is now wholly responsible for all water, sanitation, hygiene provision in schools. Making the most of the political moment, our new Prime Minister is also a champion for schools and for washing schools. We are forging new partnerships to utilise corporate and industry funds for the programme. For example, organisations like Coal India Limited, the Power Finance Corporations and Rotary International have all stepped up to the table. Inspired by West Bengal's experience, we are also seeing states begin to approach benchmarking, to begin to see how they can look at how they measure washing schools. Interestingly, this isn't always a standalone package. This is often built around other education indicators, with wash indicators integrated into the system. The Ministry of Education has now also got a new mission. The picture, the book that you can see, Swachh Bharat is Clean India, Clean Schools. This means that for the first time in India, based purely on the championing within the Ministry of Education, we have a full programme, a full set of guidelines that describe what has to happen for the health and hygiene practices of every child in school around the midday meal as the pivotal point. Above all, through the nutrition entry point, we have secured agreement that there should be an essential package of wash interventions for all schools. And this has also enabled us to make sure our investments with government in training leaders for washing schools can be institutionalised and sustained. Next slide. And so, before I finish, here is the essential package. So a minimum package for clean schools: drinking water, toilets that can be used by all, and hand washing stations. Hand washing stations in the toilet, but group hand washing around the midday meal. And look, we've been able to bring back operation and maintenance. This had fallen off the agenda completely, but through proving what we can achieve, government is ready and willing to look at operation and maintenance and take it seriously. This is not least because they are now investing in facilities themselves around the group hand washing programme, and engineers and other key decision makers within district governments are becoming interested, and they own the programme. Finally, all schools must have a package of capacity building which includes behaviour change communication work with children, with teachers and with cooks. I would be foolish to say that we don't have bottlenecks remaining. We've got a long, long way to go. We have the biggest number of schools worldwide, but we've come a long way. And of course, for UNICEF, the job isn't done. There's a long, long way to go. However, bearing in mind where we started, with a vicious circle that was going nowhere, that was stuck in the ministry with little interest, we feel we've made a confident start. Thank you.
Thank you so much, Sue. That was a fascinating presentation and really inspiring as to what we can do in other countries to really achieve the institutionalization of hand washing and other food safety and food hygiene interventions. That was great. I see that we have got over enthusiastic and slightly gone over our 1 hour plan for the webinar, but I hear from our Deputy Secretariat Director, Hannah Woodburn, that quite a few questions have been coming in. So if any of you have to leave, then we absolutely understand, and thank you so much for attending. If any of you would like to stay for a question session just for 10 minutes or so, that would be fantastic. And I will pass over to you, Hannah, to facilitate that part of the presentation. Thank you.
Well, thanks, Layla. Hi, everyone. My name is Hannah Woodburn. As Layla mentioned, I'm the Deputy Secretariat Director for the Global Public-Private Partnership for Handwashing. We do have a number of questions. The first question that we will take is from Monica Walt with FHI 360. Her question says, the duration of the intervention that OmPrasad mentioned was 3 months. Will you have the opportunity to return to the project area in another 3 or 6 months to determine the extent to which the food hygiene behaviors are still being practiced, or if the percent who are practicing the behaviors have increased?
Yes, thank you very much for the question. Yeah, we measured the effect of the intervention after completion of the intervention, 45 days after completion of the 3 months intervention trial. But since this intervention was implemented as part of my PhD, I didn't have time to go back at that particular point. But we do have a provision of going back in few years' time and assess within this year whether or not people is still practicing the behavior. Thanks. Great question.
Great, thank you. And then we have a question from Lily Dimling, which says, if hand washing is happening in schools but not at home, how is health impacted? UNICEF India, maybe you can take that question.
Well, there isn't a simple answer to that, but if you take the pragmatic view that if you've got increasing numbers of children going into school and staying in school, if you then look at the number of children that are open defecators, most children open defecating do so before they go to school. We also know in India that most children only eat at school. So by targeting schools and targeting the midday meal program, we know that we can ensure better nutrition within that moment in school. It's not a one-stop shop. It's not an answer to all the problems. It doesn't ignore the fact that we have to work very hard on increasing sanitation within the home environment. Interestingly, where there have been school award systems and benchmarking, in West Bengal as an example, schools cannot be awarded the highest rating unless the homes of those children have toilets with a hand washing station. So that we are seeing a spill out that way. Over.
Great, thank you. And then I was wondering if you could also comment on if it's challenging to keep a sustainable supply of soap at those schools since the program is so widespread.
Of course it is, but once you get a demonstration where you have local buy-in and you create demand from children, by children, this is where we're seeing a difference. One aspect that I didn't mention in the presentation is the role of children in schools. In India we have school cabinets, which are small parliaments of children who are ministers for their school. And this is where we're seeing great pressure from children demanding that soap is kept in school and that there is new supply of school. So it's all part and parcel now of finding different ways and more inventive ways to ensure that the supply chains are met. Because in India, it's not that we don't have the money for the soap, it's the motivation to buy the soap and the motivation to keep the soap for children to use. Over.
Great, thank you. Then we have one question which I think both UNICEF and perhaps OmPrasad can address, which is about how hand drying was addressed in these initiatives. OmPrasad, do you want to go first and talk about if you addressed hand washing at all, or hand drying at all?
No, I didn't try hand drying at all because the part of the promotion was encouraging people to wash their hands before feeding children. So I didn't thought about that during the trial because that I thought the first part was lacking.
In India, hand drying is drying in the air. There is no facility for towels or napkins or any other form. So in the group hand washing, as soon as a child has washed their hands, and we're practicing the wet, rub, rinse method, they shake their hands, and by the time they walk to where they're going to eat their meal, their hands are dry.
Great, thanks. So I think that addresses most of the questions that were asked. So I'm going to turn it back over to Layla to give a brief summary and wrap it up. Layla, are you there? Are you able to give a wrap up?
Oh yeah, I'm terribly sorry. For some reason it went silent there. So thank you everyone for joining us today. I think that this has been a really interesting look at all the different aspects of food hygiene and hand washing within the spectrum of World Health Day's food safety focus. I think there's a lot that we can take away and learn from here. I'd like to thank all of our speakers today for their fascinating presentations. We've heard about the importance of all the various practices that are making a critical difference in food hygiene and how we can hone in on those that make the most difference in the local context. That means doing preliminary research to understand local behaviours, motivators, barriers, and help us design effective targeted interventions that will help move people along that continuum of current practice to best practice in food hygiene. Once again, thank you everyone for participating. We will have the various links that we've referred to on the PPPHW website. You can see it there, globalhandwashing.org. And with that, thank you very much and happy World Health Day, everyone.